Bismillah ar-Rahman ar-Rahim. We are going to talk about general care of critically ill patient as a part of non-intensivist training project in Mansoura University. General care of critically ill patient concerns about many points. As for mechanically ventilated patients, the head of bed should be elevated between 30 and 45 degrees. There should be daily sedative interruption or reduction to check whether the patient is ready for weaning and extubation or not, with paying attention to mouth and eye care and prophylaxis of DVT, peptic ulcer, and pit sores. Deep venous thrombosis and venous thromboembolism show high incidence up to 33% in critically ill patients due to many factors as prolonged bed rest, presence of central venous catheters, history of previous DVT, and comorbid conditions like malignancy. Low molecular weight heparin could be used as a pharmacological method of prophylaxis in doses dependent on the specific drug used and renal function of the patient, while mechanical prophylaxis, for example, elastic compression stocking, is used when there is contraindication to pharmacological methods or combined with it, but it's less effective. Stress ulcer prophylaxis is indicated in presence of coagulopathy, history of gastrointestinal ulcers or bleeding, traumatic brain injury, burn above 35%, mechanical ventilation for more than 48 hours, or when there are two or more minor criteria including sepsis, ICU stay more than 1 week, occult GIT bleeding for 6 days, and glucocorticoid therapy. The choice of prophylactic agent depends on the balance between efficacy, cost, and potential harm. It is done using proton pump inhibitor like omeprazole or pantoprazole, or histamine 2 receptor blockers like cimetidine. Critically ill patients may develop either hyperglycemia or hypoglycemia, which prolong ICU and hospital stay and may increase in mortality. Hyperglycemia occurs either in diabetic patients or newly in the form of stress hyperglycemia and better to be treated using insulin injectables rather than oral and non-insulin injectable medications, targeting a blood glucose level of 140 to 180 mg per deciliter. While hypoglycemia occurs when blood glucose level is below 70 mg per deciliter and severe hypoglycemia below 40 mg per deciliter, with cognitive impairment starting at level of 50 mg per deciliter. Generally, in critically ill patients, enteral nutrition is preferred than parenteral unless there is contraindication to enteral feeding, as in case of shock or ongoing resuscitation with increasing doses of vasopressors. But there is no harm of enteral feeding if the patient is using stable low doses of vasopressors. About delirium and sleep, delirium is a disturbance in attention with change in cognition that develops over a short period of time and was previously known as ICU psychosis. It could be hypoactive, hyperactive, or mixed form, with hypoactive delirium as the major type in critically ill patients. Loss of circadian rhythm leads to disturbance of natural sleep-wake cycle as a medication side effect or due to pain, frequent interventions, high noise, and lighting levels. Correction of modifiable contributing factors like using visual and hearing aids if previously used, removing unnecessary invasive devices, and improving sleep hygiene by using clocks in front of the patient to help him recognize time shows great role in preventing and reducing delirium. If not, pharmacological interference is done using antidepressants, typical and atypical antipsychotics. Also, dexamethasone has shown great effect in reducing delirium incidence and duration. Critically ill patients experience pain due to many factors, including invasive devices, endotracheal tubes, chest tubes, suctioning, and wound dressings, which causes stress response and hemodynamic changes in the form of tachycardia and hypertension. It also delays mobility, leading to venous thrombosis and delirium. So the target is to maximize the patient comfort without oversedation or side effects, which could be done using multimodal analgesia rather than using opioids alone. Early mobility of critically ill patients is to be considered to avoid ICU-acquired weakness syndrome, which occurs in critically ill patients in the form of severe generalized muscle weakness without apparent neurological cause. The syndrome occurs mostly in mechanically ventilated patients in addition to other intrinsic and iatrogenic risk factors. The intrinsic risk factors include severe inflammatory response syndrome, acute respiratory distress syndrome, old age, or multi-organ failure, while iatrogenic risk factors include deep sedation, elevated blood glucose levels, prolonged bed rest, and neuromuscular blocking. Patients with comorbid diseases like hypertensive patients or patients on dialysis should receive their usual treatment with a suitable modification according to the new condition. As medical errors are not uncommon, we should pay great attention to them for safety of the patient and apply the proper infection control protocols according to the situation for safety of the patient and the medical personnel as well. All critically ill patients should be regularly evaluated as regards Glasgow Coma Scale, kidney status, with frequent lab and radiological investigations according to the patient's ongoing condition. Proper general care in critical care unit needs a multidisciplinary team formed of physiotherapy, psychotherapy, pharmacy, radiology, infection control team, and sometimes speech and language team besides the nurse and intensivist himself. Finally, all critically ill patients should get their daily routine care in the form of fast hugs in beds, please. F for feeding, A for analgesia, S for sedation, T for thromboprophylaxis, H for head-up position, U for ulcer prophylaxis, G for glycemic control, S for skin and eye care, I for indwelling catheters, N for nasogastric tube, B for bowel care, E for environment, T for de-escalation, and P for psychological support. Thank you.